Seconds.
Cool. Cool, the recording started. Well, we kind of wasted a bit of time trying to start the presentation. I'm sorry about that. We thought it would be good for you to have a look over these key terms and try and match up the definitions to the boxes whilst we're waiting for more people to join. Maybe we'll just give like 1 more minute to see if anyone else is going to join us, and you can take a look at these ones. We thought just to try and get you into the mode of thinking about psychiatric terminology before we start the case. And then we'll run through there's a table at the end, or like in a couple of slides time, so you'll get the answers as well. But we'll just give that a minute.
Yeah, and for those that have joined, there's a bit of general medicine mixed in with this. So even if you've got psych last, a lot of these you'll be kind of able to work out.
Yes.
So yeah, it should be a good case today.
Cool.
Real life case of Tina's.
Yeah.
With some embellishment.
Exactly. Cool. I'm gonna. Sorry, my laptop fan has gone on. I hope it's not too loud for you guys. I think it used to drive people mad when we had online teaching. All right. Okay, I reckon we should make a start. I'm not sure anyone else is going to be joining us. Right, so welcome to the case, or to the session. Today it's led by me, Tina, and Izzy. And we're going to go through a long case, which is based on a real case, with like a little bit of embellishment, as Izzy said, and kind of dip into general medicine, just going off feedback that we've got on previous sessions. Do you want to explain the picture is?
Yeah, this is an artist who some of you might have seen a lot of her work because it's all very funky, quite sort of psychedelic, and this was at the Tate Modern. And she's had quite a big history of mental illness. And so I guess I put this in because, you know, before med school, the stereotypes around people with mental illness is that they're not very high functioning, that it does drive their life, whereas you'll see a lot of people from a lot of different backgrounds and different educational levels and different cultures, so it does really affect anyone and everyone. And if you haven't heard of her, like, she's really cool, so check her out.
Yeah, and she's on the Tate at the moment, and we don't get sponsored for saying that. So we thought, just going through the case, we've gone through a bit of terminology, and we'll go through the table again. We've got some data interpretation for you guys, and also how to approach the psychotic presentation. So what kind of differentials you want to be coming up with, and then linking those to the relevant investigations. We're throwing in a bit of CPP as well, because it's quite a big part of psych, and also it's very SBA-able. Came up in our SBAs a couple of times as well. So yeah, this case, I saw her in A&E, and then whilst I was on liaison psych. And if you want to practice your like mental state exam, feel free to like draw out a grid and like try and fill it in as we go along, but you don't have to if psych is a bit far away in the term for you, or in the year for you. So what happened? The police brought in this lady who was in her 40s to A&E. They were called to the scene and reported that she was standing in the middle of the busy road, stopping the traffic in every single direction, just shouting at the top of her voice, like, I can stop them, I can control them, like, I'm the chosen one, I will lead everyone and they'll follow me, and just a lot of things like that. It was in February, March time, and it's still pretty cold outside, and she was literally just in a dress and slippers. So physically she was unharmed, but they brought her to A&E for her kind of basically to get checked over, and we'll talk a bit about that later. When she came through the doors, you could hear her from a mile off because she was just singing at the top of her voice, laughing. Every single person she walked past, she was trying to get them to dance and sing with her, including me. And it was a bit of a nightmare. And just like think of the psych terms that you would start employing to describe this behavior. So she got brought to an A&E side room, partly because that's what they do with like a lot of the patients who are like there's like querying mental illness or a bit unstable, but also because like she kept on trying to leave and also just kept on trying to dance with everyone, which was just a bit irritating. We did manage to get her obs. Just her heart rate was a bit fast, but everything else was fine. Started getting her bloods, even though she was like moving her arms, but she pulled the cannula out, so we only had the BBG to go off. And as you would have guessed, like an ECG just wasn't possible. We didn't have her name or age or anything at this point, and you would like ask her a question, like her name, and she would just say stuff nonsense like, okay, I made this up, but it was honestly on this level. So you would ask her name and she would say, well, I'm hungry, and then just go down this kind of route of like talking about sugar and singing like Candyman from who is it, Christina Aguilera, and then mention something like Crocodile Dundee and everything. It was just like bouncing all over the place. You really couldn't keep up. So this brings us on to some terminology. These are some terms that sort of commonly get used in psychiatry, and sometimes they get presented in a way that makes it like a little bit complicated to understand. So I think one that doesn't get really talked about enough is disorganized behavior. I hope you all managed to get that this was the kind of bizarre or self-contradictory, like purposeless behavior, and it's comes up in like a lot of different presentations in like slightly different ways. So like the schizophrenic patient might have just it might be like in a kind of negative symptoms way. That means that they're like not looking after themselves or not kind of piecing together that they need to eat and drink water to be alive. In the manic patient, it would be because they feel like they don't need to sleep or they don't need to eat because they're just high on life. So they might have like similar behavior, but for very different reasons. But what is a really important thing is because it's like a sign of their executive function, they can't function at like a higher level. So just like when you're physically ill and your homeostatic control kind of goes out the window, when you start having disorganized thoughts and behavior, that's when it's actually a really serious sign. Like a deeper level, you don't have like maintain your self-control, your identity. Flight of ideas was one of the terms I was trying to allude to. It's a type of formal thought disorder with this kind of pressured speech, which means you cannot interrupt them, no matter how hard you try. And they make these kind of rapid associations very, very fast. And there's absolutely no coherence, or like the progression of ideas becomes completely obscured. Derailment is another one that people find quite confusing. I think the main one is about loosening of associations and night smooth thinking. You might hear those ones quite a lot. It's interesting to see in real life. I've just realized I've been talking through these definitions quite a lot. I might skip through a couple of them. So I think one that comes up a lot is circumstantiality and tangentiality. So basically, if you ask a question to some people will add a lot of detail and come back to the answer at the end. And tangentiality, they'll actually go off on one track. I think the rest of them you can probably figure out for yourself, but they do come up in a lot of different scenarios, like psychiatric conditions, so it's well worth a read. Let me just go on to the next slide, because I think we're going to get you to do some stuff. So blood gas. I just want to let you all just for a few minutes just have a look at this one. How would you interpret it? And also tell me like what you're most concerned about. Yeah, Izzy's right. We'll come back to the psych terms, but I appreciate if not everyone's done psych, it might be a bit much if we're just spending a lot of time on the terminology. Oh wait, let me just get the comments up. So, right. So, once you have an idea, do you want to put how you would analyze this? And also let me know what you're most worried about. Oh, I can see we've got Neeraj here. Neeraj, we've sold on one of your slides on this. It's coming later.
Tina, was this like on room air or oxygen? This.
Oh, this was on room air.
Okay, cool.
That was important to mention. And it's a VBG, not an ABG, I should say. Anyway, all right, so this means we're slightly acidotic, but it is a VBG, remember? So you can always interpret that with like a little pinch of salt. This is slightly high, but the thing that we're actually most worried about here, actually, does anyone want to say it? What are you most worried about? Yes, very good. That is a bad sign. Everyone started freaking out when we saw this because like she seems so well. And that, yeah, so exactly. Well done, Maddie and Neeraj. Yeah, so everyone started freaking out about this. There was actually another patient who had a very similar gas reading to the point where we thought, is there something wrong with the machine? But when the using these eventually came back, like it did show that they had very low sodium. So I've just included a box of your knowledge check. So just make sure that you do know what the basic sex is, and also how you would calculate an ion gap and why that an anion gap and why that is important when there's an acidosis, because that can help you with your differentials. We've kindly borrowed this slide from Neeraj's presentation, and this is something for you to come back to in your own time, just because I know like it might be, oh, someone's hearted it, oh, that's very cute. It might be revision for some, but it might be good practice for you guys to have a look at. Right, now I'm just going to pass on to Issi, who's going to talk through the hyponatremia side.
Cool. Let me just take control. So this will definitely come up in your Jerry's placement again, and it's always good just to kind of keep these things going. And so this should just be a bit of revision for you guys. So we've got someone with a low sodium. What is our first question? Or how would we go about categorizing it to kind of identify a cause? Yep, so volume status is definitely something we're going to do. Is there something we could do before volume status? So I don't know if this was kind of covered that well before. So yeah, Maddie, great. So is it have they got low sodium, or is it a pseudo hyponatremia? So with a pseudo hyponatremia, I'll kind of go through this because it will be probably revision. So it's a state where there's too much of something else in the blood that makes the sodium look low when it's actually at a normal level. It's just been diluted out. And so if we're thinking about the sodium being the kind of the blue solutes, we've got a lot of something else that is taking up, that is kind of creating this false reading. So does anyone know some causes of pseudo hyponatremia? What else could be high in the blood that would kind of make the sodium seem low? So yeah, glucose. So someone who's got really high glucose, so who's in hyperosmolar or hypoglycemic state, or DKA might appear that way. Yep, high lipids or cholesterol, triglycerides, that kind of stuff. Brilliant. So I think those are kind of like the main two. There's another one. Well, there's two others, but one of them I only discovered the other day. So we've got high cholesterol and high lipids. We've got anything where there's lots and lots of proteins. That can be immunoglobulins. That can be malignancy as well. But I hadn't heard of that before. You've always got to think about, has someone taken that blood from an arm that has a drip in it? And so you would kind of expect everything else to be a bit off as well, like the potassium and stuff. So it's always worth thinking, has the sample actually come out the correct arm? Alcohol in the acute phase can also do this. And then there's a couple of things. So the glycine washout during a transurethral resection of the prostate, that is something that you'll kind of learn when you do urology. It's a lot more simple than it sounds, but I won't cover it today. And then, yeah, and then we're going to move on to our true hyponatremias. So people have said before that we're going to categorize that by volume, so we'll do that. But another thing that kind of can tell you whether it's true or if it's pseudo is that when you do the serum osmolality of the serum, it will be normal in pseudo because there's still the sodium there. It's just the balance of all of these things that's different. Whereas in a true one, it will be low because the sodium's actually low. Cool. So we've talked about fluid states. So does anyone know the causes? Should we start off with hypovolemic? So what are some causes of low sodium in the context of low circulating volume? This was honestly good revision for me as well, to be fair, doing these slides. So sometimes it's good to think where you're losing that sodium from. So common places that you might lose sodium is either your GI tract, your kidneys, or from kind of the skin or elsewhere into the soft tissues. So yeah, so as Patrick said, so diarrhea and vomiting would be the kind of common ways that you would lose sodium from the GI tract. Diuretics would also be a good one from losing it from the kidneys, and then there's a few other kind of renal causes. So yeah, there's the thiazides is the main culprit, and then yeah, third spacing. Yeah, you're right, Maddie. So burns is one. So you've got a fluid resuscitation is very important. It's very specialist for burns, and that's a good one to know for your exams, is how to calculate fluid replacement. Pancreatitis can also do it. Bowel obstruction can do it. Have they been running in the Sahara Desert for a prolonged period and gotten sweaty and not drunk enough? Sometimes that is quite, kind of common a way that someone might do it. Like if they're running a marathon and not keeping hydrated, then there's some kind of funky renal causes. Cool. So how about euvolemic? So normal volume status, low sodium. These are possibly kind of the kind of weird ones to think about. So yeah, SIADH, good. And we'll go on to that in a bit. Any others? I find this is usually like the weirder list to learn because the mechanisms aren't as they're not as obvious. So there's some kind of more endocrine causes. Yep. So Addison. So if there's adrenal insufficiency, you're going to lose sodium, and you're going to retain potassium. So typically they'll have a raised potassium with a normal sodium, but obviously if they get pushed too far, and it's quite a difficult one because they can also like lose water. So I don't think these are like absolute categories, but Addison's does fall into the euvolemic, and similarly hypothyroid does as well. And then this one is kind of the funky one that hardly ever happens because it's not really something that people tend to do anymore. But for people who used to be malnourished back in the day and would just drink beer is very low in solutes. And so they would basically be getting insufficient sodium in with a lot of water, and they'd get this euvolemic state with low sodium. So that's kind of one to remember for the Christmas quiz, the Royal Free. And then how about high volume states? What high volume states would cause low sodium? Yeah, so it's going to be like all the failures. So the heart and all the other ones. So yeah, heart failure. I'll just whiz through them. So heart failure. Oh, sorry, I had a whole bunch on this that I forgot. So yeah, you've got heart failure, liver failure, renal failure, nephrotic syndrome as well, because you're gonna, in all of these, you're kind of losing your albumin, you're reducing your oncotic pressure, and everything's moving out into the peripheries, and so you're intravascularly going to be low in those. Thyroid also sort of just does everything. Cool. And so Yeah, so fluid status is the most important thing to ask first, and then you're going to want to compare the serum with the urine, because if you're thinking about a renal cause, if it's being renally excreted, you're going to see it in the urine. So you want to do those kind of paired tests. The ones that I didn't mention was that obviously we give people fluid resuscitation in hospital, and so if we don't get those levels right, so if you gave someone just IV dextrose or something that lacks any sodium in it, we can give someone euvolemic hyponatremia. And then also if someone is drinking lots and lots of water for whatever reason, excessively, that can also cause it. And your kidneys can, I think the maximum is about 12 litres a day of urine your kidneys can produce. So if you're taking in more than that, your kidneys aren't going to be able to cope with that. And then some drugs as well can make you drink lots of water. Cool. So management of hyponatremia. So does anyone remember what symptoms these people can have and what the most worrying things for hyponatremia are clinically? So why do we get this? So why would we be very, very worried about this woman having a sodium of 119? Anyone got any ideas? Oh, nice. So yeah, the extreme end is going to be the seizures and coma. So yeah, but more they usually present more non-specifically and not at that point where they can kind of be a bit muddled, have some behavior change, and yeah, have some confusion, and they can get ataxia as well. So in general, I think you can see these symptoms at different levels. I think obviously the elderly have much less resilience for these kind of changes. Also, it depends on whether it's an acute hyponatremia or a chronic one. So obviously, if it's acute, you decompensate quite quickly, whereas with a chronic picture, you kind of can sit at that level quite asymptomatically. And so those are the things that we worry about, and that's why we correct it. But obviously, we've got to be cautious about correcting hyponatremia. So if in the blood there's not much sodium, and in the brain there's lots of sodium, what's the problem there? Where will the water go? I'm thinking about osmosis. What can that lead to if you have hyponatremia? Sorry. So if someone has hyponatremia, and it's here, so they haven't got much sodium in their blood compared to their brain, what's the kind of complication of that? As water usually follows the sodium. Yeah, so Niraj, those are kind of the two kind of spectrums. So the thing that we'd worry about here, and these diagrams, Reg once kind of drew these out for me, so I kind of copied it. But essentially the water's going to flow from the low sodium concentration to the high sodium concentration. So that's kind of going to give us cerebral edema. And so we obviously want to correct that. But if we correct it too fast, then we're going to get the other complication, which is where the water's all going to come out of the brain, out of the cells, into the vasculature, and you're going to get this pontine myelinolysis. And this is the kind of classic SBA of usually I think it's young women that are most prone to it. If you do it too quickly, they get confusion and they can get decerebrate posturing and can get brain damage because all that water has just gone, into the blood. So those are the kind of two ends of the spectrum that we worry about. And so we then aim to not correct the sodium too quickly. They do it a bit quicker if someone is, you know, having seizures and convulsions, that kind of stuff. But otherwise, you're aiming for a maximum of 12 millimoles change over 24 hours. And for things like using hypertonic saline and stuff is very much like an ITU decision. So yeah, cool. Okay, so for this lady, we begin our sorting her sodium out, start doing that slowly. And so now it's kind of the consideration of like what has caused this low sodium in the first place. And so the SHO brings you over her bag of medications, and they're listed below. So just have a look at those. So there's levetiracetam, bisoprolol, citalopram, and paracetamol. And then the paramedics have also found a whole bunch of things in her flat, which include these guys. And so there's two main things on this page, which would be your kind of big ones that you think could mess with her sodium. So just have a think about which two you'd go for and just pop it in the chat. Even if you don't know like what it might do to the sodium, just like have a think about which ones can kind of are kind of the red flag ones for messing with your sodium. And I think with the things below, it's not something that's taught about very much in med school, but you'll see it a lot on your psych placement of people with addiction issues. So it's good to kind of have a bit of a knowledge, even if it doesn't come up in SBAs too commonly. So yeah, we've got, so citalopram is the big one for prescribed medications, so SSRIs in general, and then ecstasy as well can cause polydipsia as well. So those would be our two kind of things that we're thinking about that that she might have used, might have caused this. So a little bit about ecstasy, just because they don't teach it very much, and it is quite an interesting drug actually. So the other name for it is of course MDMA, and it was originally found actually kind of scientifically, they found it quite interesting because it kind of created these feelings of empathy, and psychiatrists were quite big on it. And then they realized that it was actually something that people could abuse and had these issues with sodium and had toxicity. So kind of went out of favor in the scientific world, and then kind of became something in the kind of recreational world. So the way it works is that it affects a number of neurotransmitters, but the big one is serotonin. So it affects its reuptake and also its breakdown. And so a lot of the complications can happen because of high sodium. Does anyone know how someone who's on ecstasy can look? There's like certain side effects to taking it or taking too much. So if you're thinking about it raises your serotonin, so what might happen? Otherwise, I'll just tell you guys about it. So people can have certain facial characteristics on. So yeah, sweating is good. Dilated pupils as well. So it does trigger this, does trigger your fight and flight response as well. It acts on noradrenaline and dopamine. So it gives you this euphoria, but it can also give you high blood pressure, sweating, that kind of stuff. They also get this jaw clenching that they do, which can look very characteristic and is colloquially called gurning. They get a dry mouth as well, which makes them want to drink more as well. And they can even bite their tongue as well because they kind of crave this chewing. So I think Tina and I were talking about this earlier, and how people have they'll have lollipops at raves and stuff because they kind of have this like wanting to chew stuff. And then it can also mess with your sodium. and it affects transport of water out of cells as well. So if you drink too much water, you can end up with your cells basically all swell. It's really grim. And then it can cause hypothermia as well in the context of serotonin syndrome. And they'll also get features of hypotonia and myoclonus as well. So that's a good one to know. I think for psychiatry, they're quite big on the difference between serotonin syndrome and neuroleptic malignant syndrome. We'll go over that in a future session because they're both quite similar, so it can be good to go over. Cool. So the thing that we were worried about first was whether the citalopram was causing an SIADH. And so SIADH is a syndrome of inappropriate ADH production. So as you know, like ADH acts on your on the collecting ducts, and so in your kidney, and so it basically increases water reuptake into your body, and you also lose your sodium as well. And so this can cause up to 1/3 of hyponatremia cases, so it is quite common. There are a number of drugs that cause it. Does anyone know any others that, apart from SSRIs and ecstasy? So there's one that's a favorite in the lupus clinic. There's another one that's a favorite in oncology, but these are kind of like less common. And then if you don't know those, have a think about what this chest X-ray might be alluding to, and pop that in as well as like another cause of SIADH. Yep, so cyclophosphamide is the rheumatology drug that can cause it, but obviously not many people are on that drug, but it is one that causes it. Does anyone know what this chest X-ray might be showing? It's obviously, a very rotated film, but there's one abnormality on it. If you just look at the heart borders, that will kind of give you a bit of an indication as to what might be going on, which is the cause of SIADH. It's kind of the classic 4th year SVO. So if I was to tell you that this person has a lung cancer, which lung cancer causes SIADH? And I'll just put through the drug causes, like while we do that. There's quite a mix to know. So yeah, Patrick, well done. So small cell lung cancer is a cause of SIADH. So if you've got someone with that, you might be considering a malignancy. There's quite a few that cause it, but that's the kind of classic one that you learn in 4th year. Drug causes wise, it's just good to know basically SSRIs and tricyclics. And I think NSAIDs is another good one just because they're very commonly used and can cause SIADH. Cool. And so the big one for this is that we're going to expect a low serum osmolality and a high urine osmolality because that's where the sodium's going into the urine. So for this lady, you do her test, and she's got a low serum osmolality and a low urine osmolality. So do we think that she's got SIADH? Yes or no? So because the urine sodium isn't raised, we're not thinking that this is coming from the kidneys. And so, yeah, Laura, so it's not SIADH for this one. So we're kind of left with our alternative drug cause. And I'll just go through the management as well in a bit. So we're not thinking this is a SIADH. We're not thinking it's a citalopram. We're kind of thinking about like psychiatric polydipsia as well. And so for the management in general, for SIADH is your fluid restriction, and there's some drugs that you can go over. I don't think this is so much of a fifth year topic, so just something just to read up in your own time, just to remind yourself for the finals. But otherwise, we can just keep going. So let's have a look. So psychogenic polydipsia, this is seen in people with psychiatric illness. So like in this lady, there's a evident psychosis going on as well, and also that she's got this history of drug use. And so it can be seen in that context. It can also be seen in healthy people who think it's normal to drink liters and liters of water a day and kind of go to the gym. So they have seen that before. And so the thing to think about is if someone's producing a lot of urine, we just want to make sure there's not a kind of organic process going on before we make this. And so once we've ruled out other causes of hyponatremia and diabetes insipidus, we can kind of think about this as a diagnosis. Cool. So I will hand back over to Tina. If anyone has any questions, I can answer them in the chat. Cool.
Hi, I'm back. Yeah, no, so thanks, Izzy, for going through that. So electrolyte imbalances is something that I kind of really wish that I looked over more in fourth year and fifth year for sure. Like, because I think once you get to like the clinical setting, it just comes up all the time, like as a sort of someone will be like, oh, what's the cause of like hyponatremia or something like that, and just to have that like kind of structure in the forefront of your brain and to know what tests that you want to do to kind of distinguish between the different causes is really important. So it's well worth learning now to kind of save yourself later. So right, we're going to come back to the case. So we've got a little bit of interpretation for you to do. So this is not her ECG, but it's highlighting a point. So try and go through it systematically, if you can. So I hope everyone has a system. Mine is rate, rhythm, are P waves present? Are they like a normal shape? What's the PR interval like? What's the QRS morphology like? Is it narrow? Is it broad? Basically, is there any axis deviation? And someone might have spotted what the thing is before I say it, but the QT interval is also important to consider. Are there any additional waves as well? So even if you don't know exactly what's going on, having a system is really, really important. How confident do people feel with ECGs? Because you got one bit of feedback that was like you want to do more ECGs. Or can anyone tell me what's going on here?
Is it just tall tented T waves? Is that what this is?
I agree, they do look a little bit abnormal, a little bit large. That's not quite what this is, but I agree they are quite big and quite wide. So what else about the T wave? What's quite long in this? Well, I might go through it because I don't want to take up too much of your time. So can you see from the beginning of the Q? Oh, yes, well done, Laura and oops, who's it? And Lena, well done, you got it. I wasn't sure how many clues to give you guys, but yeah, well done for getting it. And I agree with you. I think it was Patrick who said that they did look a little bit abnormal. You're right, and well done for spotting that. So yes, this is an ECG showing a long QT interval. I think when I had a look at it, it was almost like Yeah, it was like almost like half a second, which is far too long. So normally it's about under 440 in men and under 460 in women. And once it starts going above 500 milliseconds, that's when you get at risk of like complications. So well done for picking that up. So does anyone know any causes of long QT syndrome?
We're doing like all the throwbacks today.
Exactly. Yes, low potassium. That's good. Oh, I've accidentally clicked and given you one of the answers. So, what other electrolytes will cause long QT? Long QT. Yes, very good. That's really good. So yeah, actually, there's tons of causes. There can also be some like natural variants which are a little bit long as well. But definitely, so myocardial disease, I've given you that one away. Quite a rogue one is raised ICP, which is, does anyone know what other features you might see if someone's got very, very high intracranial pressure? There's a certain reflex or a triad associated with that. Does anyone know what it is? Not so much to do with the ECG, but maybe their blood pressure or heart rate. Does anyone know that? Sorry, I'll give it to you. It's the Cushing reflex. Does that ring a bell? So it's basically when it's quite a late sign of raised intracranial pressure. And basically what you get is Cushing's triad. So you get high blood pressure, slow heart rate, bradycardia, and irregular breathing. So if you've got that, those are quite bad signs of raised intracranial pressure. And you can also, if you do an ECG, get long QT syndrome. There's some genetic causes. These are just, you don't need to know about them, but sometimes it's quite good to recognize if it ever comes up in SBA, you know what it is, and you can either rule it in or rule it out. So I'll just like let those sink into your subconscious. Electrolytes, as someone mentioned, we've got hypokalemia, low magnesium and low calcium. Hypothermia is another one. Oh, sorry, I gave that one away too. Does anyone know what other wave we sometimes see in hypothermia? Sometimes you get an additional sign. It's a bit hard without seeing the ECGs, I'll grant you that. But you can get a J wave. I hope you guys have heard of that. Are you? Yeah, well done. Sorry, I'm not giving you guys enough time to answer. Well done. What do you see the U wave in? Does anyone know? Was it? Yeah? I think so. And what else do you see it in? You can see it in this, I think we've mentioned it as well. So really, really low potassium. And I think quite a few other things. But yes. Good. And then drugs are lots and lots and lots of drugs. So think about antibiotics, antimicrobials, antimalarials, antipsychotics, antihistamines, and antiarrhythmics. There's so many like within those. I know it's not the most helpful, but learning a couple of the main ones and learning why they're relevant to, so say this condition, or this case in particular. So SSRIs, and they can add up as well. So someone can have, if they're taking SSRIs and they're also taking Ecstasy, or you're thinking about adding antipsychotics. That's why it's really relevant to this case in particular. Does anyone know what this is as a complication? Yes, well done. Well done. Okay, and it also reminds me of that album cover from the Arctic Monkeys, but maybe that's just me. So do you know what we give to treat dressage? Or if you see that, what should you give them? What's the sort of electrolyte you need to be thinking of first when you see that? Yes, well done, fantastic, all of you, well done. Okay, so yes, you got it. Dressage de poids. You want to give magnesium sulfate. They might need electrocardioversion, but again, that won't be us doing that. Treat the underlying cause, and you might have to consider a pacemaker. So if they've got like a genetic cause or like some sort of chronic cause of long QT syndrome that continually puts them into that, that's what you have to consider. So we're going to come back to the case and bring in a bit of CPP. So this woman she was fine at the moment, but she wasn't being very productive. Wasn't being very receptive to kind of medical treatment. So we just want to start thinking about what can you do if a patient isn't accepting medical treatment in A&E. So, I was going to ask you guys. So yes, you can do a capacity assessment. Does anyone remember the process or any of the criteria for capacity? Or assessing capacity? I think you must have done it in 4th year, and you'll definitely do it again in 5th year. So it'll be on the next slide, but feel free to post it as I keep talking. So another thing is a risk assessment. So whether they're a harm or like a danger to themselves or a danger to others. And the last thing is what kind of response. So it has to be proportionate, has to be in their best interest, and it has to be the least restrictive. I'm hoping some of this rings a bell. So think about capacity. So I'm going to do the first stage of it. Oh yeah, so in this case, she actually consented to having an injection of lorazepam, just to sort of take the edge off, because she said, you know, her mind was racing and she kind of she did say she wanted to calm down at some point. So they kind of took that as like consenting for lorazepam. But if she hadn't, then there is kind of a flow chart that you need to work through. So as I mentioned, it's a 2-step process. The first question you have to ask yourself, is there an indication to do a capacity assessment? Which seems a bit odd, but before you even start assessing someone, is there a need to? So they've given a lot of examples in box 1. So this is taken from the Royal College of Emergency Medicine guideline. I can really recommend having a look at it because it was really helped me think through these things. So if someone has a mental disorder, a brain injury, they're intoxicated, delirium is another big one for assessing capacity. And remember, this is under the Mental Capacity Act. So stage 2 is about, does the impairment that whatever it is that deemed you thinking it was necessary to do assess their capacity, is that impairing their ability to make decisions? So does it ring a bell that the 4 things of like, can you understand, retain, use, or weigh up information and communicate that? I think you definitely must have done that at some point. This is something that is really good to practice doing an OSCE station on. Good, Maddie, I'm glad. Thank you. Keep responding, guys, otherwise I'm going to keep asking you questions and just not getting any answers back. Definitely practice with your friends who are like acting as patients and acting as doctors about doing a capacity assessment, because in real life it's really, really weird to sort of be like, can you retain this information? You need to come up with ways to gather that kind of thing without kind of explicitly being like, oh, now I'm going to assess this and now I'm going to assess this. So the other flowchart, and this is a bit complicated, definitely have a look at this in your own time, is in A&E, because A&E is a public space rather than the ward, which is a private space. What you're actually able to do. And this kind of links together the 3, or like the kind of different domains of the law. So you've got like the Mental Capacity Act, which is in orange. that we just talked through. You've got the Mental Health Act, which is in blue, which deals with people's rights when they're under sectioning. And then you've got common law, and that tends to be when there's a risk to, like, an immediate risk to someone or someone else, or others, and there isn't time to do a proper assessment. That's when you can invoke common law to prevent significant harm. We've got some scenarios to work through later, and we'll talk that through after we've explained the sectioning process. I hope this is not too much information. Some of it should sound familiar. So the sectioning process, it is a group decision. It's never really on one person just to do. There's a couple of kind of terms to be aware of. One is the AMP, or approved mental health professional, who is not a doctor. It can be a nurse and psychologist, anything like that, but just not a doctor. Then there's a Section 12 approved doctor, and that's just a doctor who has experience in sectioning people, and another healthcare professional who's who advocates for the patient. Another important person is the nearest relative, who can sometimes also ask their relative, the patient, to be sectioned. Later, they'll be assigned like an advocate who will just make sure that their rights are being protected whilst they're under section. And as I mentioned, the location matters. A is a public space. They really love that in SBAs to catch you out on the sectioning process. Right, so let's just talk through a couple of the main sections. There are a lot, as you can see. We started high with 135, but I've listed the main ones that you definitely should know. The first one relates to the police, whether they can detain someone at home or in a public space. So that's a section 135 and a 136. The emergency section is section 4. So that is if you don't have time to do a full assessment, but you do have a doctor and an AMP or a relative, so someone who knows the patient well, and you can do an emergency section to take them to hospital for assessment. Under that section, they cannot be treated without their consent. The other sections to be aware of are a 5.2 and a 5.4. So those are the hospital holding powers. The doctor can hold a patient for 72 hours in order to have a formal assessment. A nurse can do that under a 5.4, but only for 6 hours, until a doctor can either extend that up to 72 hours, but they have to get a formal assessment during that time. I know this is quite dry and quite legal, a lot of legal stuff, but I've really distilled it down to the essential information for you guys. So the section 2 is 28 days. That is usually not extended or renewed, but would just make, if someone needed to stay and be treated, that would convert to a section 3. Which is initially 6 months, and then it gets renewed for another 6 months, and then basically after that renewal, it can be 12 months, and each subsequent one can be 12 months, and there's actually no upper limit. So long as doctors or psychiatrists think it's necessary for them, it could be a long time. So other things to go away and look up are the appeal process and mental health tribunals, and I can really recommend the Mind website. They have a really fantastic legal section, and that really helped clear up things for me. So I hope you're all paying attention. I've got some quick case studies to go through. The first one, maybe we'll just do a couple of them, because I realise it's 7 o'clock now and we've got a few things to go through still. But let's go for the first one. A 60-year-old woman with known schizophrenia has barricaded herself into her flat and is refusing food and drink. What section could we do for that one, or applies to that one? Or if you can't remember the number, just the description of it. Okay, so say we need a warrant to get into their house. Who would we need to help us? Yes, definitely. So this would be a section 135. because you definitely would need the police to come and help and detain the person from a place that's private. If it was in a public space, they could use a 136, and I think the police prefer that because it's a lot less paperwork, or that's like what I've been told. So let's do another one. What about the number 3? A 33-year-old male is brought to GP by his mum. He's got psychotic symptoms and is deemed to be a danger to himself, but refuses to go to hospital despite his mum's requests. So what one, if we have the GP and the mum can act as the nearest relative, but we're in a GP, so that's a public setting. So that rules out, yes, well done, Maddie. Well done, and well done, Patrick, you got those. Very good. Let's do, okay, this is a bit of a trick one. 18-year-old female falls off her bike without wearing a helmet and hits her head, but she's got capacity and wants to cycle home. Can we do anything? It is a trick one. Nope. Yeah, well done. Yeah, we can't do anything. We can't, mollycoddle everyone, and we just advise them, like, please wear a helmet and be careful on your ride home. But she's got capacity. She's not a threat to anyone. So yeah, we can't do anything. Cool. So we've got on the next slide, just for the sake of time, I'll go forward. Number 6, I think is something we'll come back to because so she has delirium. So what you can do is complete a form called like a DOL. So this is actually under the Mental Capacity Act rather than the Mental Health Act. But that's something I think we should come back to because I think that's quite complicated, and we'll definitely do a Jerry session where that gets talked about a lot. Right. So kind of back to the case. I was going to go through the elements of a mental state exam. I'm not sure we have all too much time. And there is a really good video from a previous year on the mental state exam. When you start your psych placement, I would definitely recommend watching. I would just, I think the point that I wanted to make here was that when you present a mental state exam, it's very similar to how you would present any other kind of examination. So you would have your intro, I assessed Miss Jane Doe with unknown past medical history in A&E and wrote up a mental state exam or something like that. You would include your important positive findings. So she was hyperactive, disinhibited, had disorganized behavior, pressured speech, signs of a formal thought disorder, things like that. And then important negative symptoms would be things like no negative symptoms. So like doesn't appear to be suffering from a kind of schizophrenic type psychosis. And no signs of thought blocks. She had normal perceptions, so like no hallucinations, no illusions, like things like that. And then be honest about what you weren't able to assess. So I wasn't able to assess her cognition, but like once more stable, I would use an accredited tool, etc., etc. And then also like always do a risk assessment. I'll just go through to the next. Sorry if I'm rushing a little bit. So just to talk about psychosis, it is a symptom complex and include a lot of the things that we've talked about. So the disorganized speech and behavior, thought disorders, altered perceptions like delusions and hallucinations, and lack of insight. It is a really key symptom of severe mental illness, but in itself, it's not a diagnosis. We use like a couple of different terms to describe it. So functional or organic. I'll go through how what we mean by that in a second. And acute episodes can be primary, so like due to like a mental illness, or secondary, so to a medical condition or a physical condition. It's really important to exclude or treat the organic and secondary conditions first, because someone might have something reversible that you then start treating as a psychiatric condition. Yeah, I think I might wrap up a little bit because I think once we get to 10 past, that'll be on the hour. This is just to say that there are lots of different types of organic causes of psychosis, and these are the relevant investigations. I've sorted it by the surgical sieve. I'm not sure if anyone else uses that, but sometimes I use it just to kind of explode all the different possibilities that it could be. I think my point here was, I get asked a lot, if you do an investigation, what's it for? So always like have if you want to test for something or rule something out, like have a specific test, or like that's your reason for having that test. Okay, I think some of them are quite obvious. So like thyrotoxicosis, you might have heard of that one. Or people can become like psychotic even with something like sepsis or like encephalitis. But that's something to look at maybe in your own time, because we don't have enough time to go through it today. The other things are functional causes of psychosis. So that's when there isn't a structural or like pharmacological problem. And different types of psychosis have like different flavors, as one doctor said to me, as you can imagine. So with postpartum psychosis, there might be like obsessions around the baby itself. In a schizophrenic one, there might be a lot more negative symptoms, which is, a long kind of steady decline in ability to like look after oneself or socialize. In a bipolar disorder, if it's a manic psychosis, their mood will be elevated. They'll be exhibiting signs of like grandiosity and have flight of ideas, just like Our Lady. Or depression with psychotic features, it will also be congruent with those depressive symptoms. Right, so just before 10 past, how did it end? We eventually got her name and can access her record. So the HIA is just health information exchanged. She was diagnosed with bipolar in the past, but she was lost to follow-up. Her urine drug sample, which we eventually got, came back positive for cocaine. So I think the working diagnosis was that she did have bipolar, and the cocaine was sort of drug-induced psychosis. So the plan was to refer her to the community drugs and alcohol service, and back to community psych. So just as a sort of last slide, how you would manage like a manic episode, much like a psychotic episode, exclude organic causes. And if they're not in need, so if they're manic, they might actually not need to be admitted. They might be able to do like tests as an outpatient. But the important thing, excludes the organic, like have a system. So assess them, like do they need to be admitted, exclude organic causes, stop antidepressants if they're on any other medications or drugs. If they are refusing treatment or a danger to themselves, then you can have like kind of a rapid tranquilization protocol. So that would be like the Razapam, but that's for the short-term only. I think the key things, everyone associates lithium with mania or like bipolar disorder, but just remember in the acute phase, you actually want to use antipsychotics, and anti-epileptics can be like an adjunct to that. And then in the long-term biopsychosocial approach, that magic word, with lithium and maybe some anti-epileptics like valproate. But yes, okay, 10 past 7, we made it. I hope that wasn't too rushed at the end for all of you guys. On the slides, I've included so 2 OSCE things that I put together in 5th year. One was for mental state exams, and the other one was like an explanation station of explaining the sectioning process to someone. So just feel free to use those. I hope that helps. It definitely helped me, like to write OSCE stations helped clear up things that I found really confusing. But yeah, thanks for staying to the end, guys.
Yeah, thanks, guys. I've just put the feedback form in the chat. There's only kind of like a few of you left, so your feedback would be really appreciated. It'd be good to know what you think about the structure of this session. If it was like too much content or anything like that, let us know. I think we were trying to do like a combination of a bit of 5th year and a bit of Gen Med for keeping up your 4th year knowledge. And yeah, let us know what you would like in the next sessions. So that's what we're going off.
Yeah.
But otherwise, have a really nice evening. Enjoy the rest of your week.
Okay, well done everyone, and thank you for replying. I hope you enjoy the rest of your week. And do they test a lot of fourth year content in fifth year? I'd say it